procedures. We do total ethmoidectomies, septoplasties, polypectomy, things like that, which we'll talk about here shortly. At first, we were a little concerned about how our patients would accept local anesthesia. Would they shy away from that? Would they be negative to that? But they've been very accepting of local anesthesia. I would tell you that they take their cues from us. So if we're very confident in our approach to being able to treat them in an ambulatory setting under local very comfortably and very safely and effectively, they'll be very happy. And we've seen patients express a number of benefits that they've realized and that we have seen, and I'll be sharing with you, doing things in that environment. In the US, the vast majority of balloon dilations, probably 70% now, are done under local. And for me, 80 to 90%. So why did I make this transformation to a minimally invasive approach in an ambulatory setting? First, this technology really was revolutionary, and we're finding that it's become a very important part of our treatment for CRS. FES is still a very key part of what we do, but balloon dilation has a significant positive impact on what we can treat with that. And I'll share some of the tips and things that we found. It's minimally invasive. It preserves anatomy, preserves mucosa, effectively restores the outflow tract, and in many studies for uncomplicated CRS, it's equivalent to FES. Many advantages, we're going to be talking about those here shortly, over doing FES in the OR. And what I always ask myself is, what would I want if I was a patient that needed to have treatment for CRS? This is definitely the approach that I would want. So we've seen a number of advantages in making this transition: safety, recovery, economic, scheduling, and certainly comfort. I'm going to go through each one of those individually. From a safety standpoint, we have significantly less bleeding. Anyone who's done these cases in an ambulatory setting under local can testify to the amazing lack of bleeding. So you can see your landmarks much better, just better visualization overall. The patient is able to give you feedback. So if you're impinging on a critical structure, they'll let you know. And sometimes I'll let them know, I'm going to be working in this area around your eye. If you have a lot of pressure there, let me know. And so that adds a big level of safety. In addition, there are significantly reduced cardiopulmonary risks compared to general anesthesia. So I'm able to do a lot of patients that may not have even qualified for general anesthesia because of comorbidities. We can very safely treat them in the office, and they're very happy. Their cardiologists are very happy, and it adds a whole new pool of patients to your list. Certainly, recovery time is amazing. I do most of my cases on Fridays, and they're back to work or school on Monday. And this is after balloon dilation, after ethmoidectomy, septoplasty, whatever we do. The majority are back on Monday. There's just less blood loss, there's less tissue trauma, and no general anesthesia. Being from Augusta, we have to show off Augusta National a little bit, so that's the famous clubhouse. So there's lower costs, so there's some real economic advantages. It's lower cost to the patient. Often there's just an office copay. It's certainly less costly for the healthcare system. There's no anesthesia fee, there's no facility fee, and it requires a lot fewer staff. From a revenue standpoint, the patient referrals are significant. When patients begin to learn about minimally invasive approaches to their sinusitis, they are very interested in taking that approach. Minimally invasive approaches, very popular, they're very interested in those, and so you'll start to get more and more referrals when you become known as the physician that treats sinusitis this way. In addition, you really have a new pool of candidates, not only from the standpoint of the anesthesia, but also many patients have shared with me that whether accurate or not, we know a lot of negative connotations about sinus surgery, and that scares a lot of people. And so They told me they would never have come in until they heard about this procedure that can be done in their local with a minimally invasive approach. So it's a whole new set of patients. And then in the U.S., I know it's different in other countries, but in the U.S., they have actually incentivized the move to an ambulatory setting because of the reduced cost. So from a reimbursement procedure for clinicians, it's very positive. Scheduling is a big advantage. As Raj talked about, list time is critical. It's precious. And we're able to accommodate a lot more patients in a timely fashion. So timely intervention comes in again here, that we're able to take care of these patients really anytime we'd like to, because we control the schedule. And it's much easier to accommodate our patients that travel long distance. Oftentimes I can do them that very day, if necessary. And when you train your staff, you can have very efficient case flow, very efficient turnover, often much better than we see in the operating theater. And last but not least, patient comfort. Much higher patient satisfaction scores compared to FES in the OR. There's less nausea, less post-procedure pain, and the opioid epidemic is certainly a huge factor in the U.S. I'm sure it's really worldwide, and they require much less narcotic. Most of my patients take Tylenol, maybe a few hydrocodone, very little post-op pain medicine required. And they're happy. They're very pleased with their result. They'll go home, they'll tell their family and friends what a good experience it was, and then the patients just keep coming. So these are the keys, advantages that we've found in offering this approach to our patients. And I'd encourage you to really look at this approach as well. So this is hole number 10. All right, patient selection. So how do we choose our patients for an ambulatory setting, treating them with balloon sinus dilation and adjunctive procedures? So we don't just handle minimal disease, chip shot patients. We can handle significant inflammatory disease, mucosal thickening, inspissated mucus, a mild amount of fungal debris, mild moderate polyposis. We can handle those very well. You just can't dilate a sinus and leave it, though, with significant inflammation. So it's very critical to pair that with medicated irrigations that we do at the time of the procedure. We have medicated gels that we put in that have steroids and antibiotics that are culture directed. And we can do this during the procedure and at subsequent visits. So as we know, whether it's FES or balloon dilation, just addressing the access to the sinus often isn't enough. We have to address the mucosal inflammation and the disease at the level of the mucosa inside the sinus. And that's why these topicals are just so important. So as far as indications, we can handle recurrent acute, mild to moderate CRS. We can handle septal deviations, ethmoidectomy, polyposis, mucus, and mild fungal debris. Certain revision cases are very well handled in an ambulatory setting with this approach. The main contraindications that I use are significant moderate to severe fungal disease, heavy hand polyposis, or if they have significant osteitis or osteoneogenesis. Those patients just need a much more invasive approach with our FES techniques in the OR. So using this filter, this is where I'm at today. I treat 80 to 90% of my adult patients with balloon dilation with or without ethmoidectomy or other adjunctive procedures, and 90% of those are in the ambulatory setting with local anesthesia, and 10% still in the OR. Children, I treat primarily with balloon sinus dilation with or without an ethmoidectomy or an adenoidectomy, and most of those obviously are in the OR. The keys that we have found for success in being able to offer this type of approach to doing things in an ambulatory setting or local are foundational is the sedation and anesthesia protocol. So I'm going to go over that in detail here in just a minute, but there's some other things that are really important. You have to have the right equipment and technology, and one thing that we've really appreciated in partnering with Stryker is that they really have kind of built the ambulatory suite of the future and all the things we need they can provide. The 3mm scopes have been really transforming to be able to have such a small scope with a adult-sized scope view. The shaver really opens up your opportunities beyond balloon dilation. We just started with balloon dilation, very simple equipment needs, and then built from there. And adding the shaver is a big step because then you can handle polyps and turbinate reductions and ethmoidectomies more efficiently. So those things are very important. The MiniFest instruments are excellent. We've added image guidance, so we have more confidence in taking more complicated cases and revisions to the ambulatory setting. Cyclone suction irrigation really helps with significant inflammatory disease and large amounts of inspissated mucus and those mild fungal patients. A peer-to-peer visit is really critical. That's just spending a day with one of your colleagues who has a lot of experience treating these patients in that setting and sharing, the office flow, the techniques, and just going to see it makes a big difference. And it was a big impact in my practice, and many of my colleagues that have done these visits have really been complimentary of the advantage of doing that. So I'd highly encourage that. You have to train your staff well. We had our surgical team actually come and train our ambulatory folks on how to, run a little procedure room, turn over the instruments, how to hand them to you. And so that was really helpful. And then you have to commit to the transition. You just have to realize that, as I believe, it's the way of the future because of the cost savings, the safety, all those advantages that we mentioned. I think this is the trend of the future. And so the earlier we can commit to making that transition, the more ahead we'll be of the curve. But you have to just work through that process and go through that transition. If you're able to do that, you can very easily handle all these minimally invasive approaches and be able to provide a significant amount of treatment to your patient in this setting. So that's amen corner. All right, let's conclude with just briefly going through the sedation and anesthesia protocol that I use. This is foundational to success in this. So the patient, we use triazolam. It has a much shorter half-life than Valium. And so 0.125 is equivalent approximately to 10 of Valium, as you see there. We give 10 of Norco, and then when the patient comes into the office, they take another 0.125 of triazolam. We also give some Phenergan, and then we reassess. Usually, the 2 doses of triazolam, which is about 20 of Valium, are adequate. But I was doing a lot of cases on Friday, and I had a young man after 2 doses of triazolam who just wasn't drowsy at all, and we gave a 3rd dose, and he did very well. So I've given 4 doses of triazolam, which is about 40 of Valium, depending on the patient's metabolism, and sometimes that's required. It's very safe. Once the patient is ready to go, we spray with Ponocaine and Afrin, 1-to-1. Usually 5 or 10 minutes is plenty for that. And then I place the pledgets. The pledget solution is an epi 1-to-1,000, diluted with lidocaine 4%. And it's 1-to-2. If I have a patient who has a cardiopulmonary problem, someone who's over 70, anyone I'm worried about from just a cardiovascular standpoint, we have a mixture of 1-to-3. And with that type of approach, we've not had any issues with arrhythmias or any cardiac events. And these are the standard placement of those pledgets, which you're all familiar with. And with that, when we do the injections, the patient does not even feel the injection, which is really important and very nice. I put this up there just for disclosure. As much as I preach this and I go to great lengths to avoid this. This happened Friday. I had a patient that I thought was just fine and started doing that, and it just makes for a very unpleasant case. So it'll still happen once in a while, but if you really pay attention and do some of these techniques I want to talk about, you can avoid this. So when they're getting sprayed, we have them tilt forward so any excess comes forward. We wring out any excess solution from the pledgets before I put them in. We often put some packing in the back to absorb any drainage. And then your injections are critical, not only from the anesthesia standpoint, but you want to go slow, controlled, and not spray. And a short bevel needle can really help with that, and I'll talk about that in a minute. And then just during the case, you have to be aware. Sometimes my staff will remind me to keep suctioning the back of the throat if there's any buildup back there. And using that, it's very infrequent, very uncommon to have that, but it still happens to us with best intentions. All right. This is the bridge over to the green on number 12. So this is the needle I was mentioning. It's called the reinforced anesthesia needle. Hopefully Stryker will have that available soon. This is a game changer. It makes you look really good. I'm not the best in injections. I'm not the best technique and the best hands, but this needle makes you look good. It slides in 2 millimeters, and then you've got that backstop. It's a short bevel. It's 27 gauge at the end, so it's just a great instrument. It just gives very good submucosal diffusion. So I'd highly recommend you try this. The length of it is about 3.5 inches, 3 to 3.5, and you can get back to do a sphenopalatine block. You can inject the rostrum, just get anywhere you want to go. It's very nice, and because it's reinforced, it's not floppy like a 25 gauge spinal needle. And yet at the end, it's 27 gauge, so it's very low profile. So our injection mixture is a 4% prilocaine with 1 to 200 of epi. Because the bleeding is such a non-issue in the ambulatory setting, we're able to get by with less epinephrine. And so we have very little, again, cardiopulmonary side effects. So about 10 minutes before the procedure, we'll do the injections. These are the typical places all of us do these. I know you're aware